Hello, everyone, and thank you so much for joining us. This is Echo Asthma Bootcamp, Module 2, Phenotypes of Severe Asthma. My name is Ashley. I'm your facilitator. I'm joined today by my coordinator, Rachel. And
Hey, everyone.
Sorry, Rachel, go ahead.
No, hi, everyone. It's nice to see you all again. Happy Tuesday.
Happy Tuesday. We're also joined by our fantastic hub team. We have Dr. Mandeep Jassal and Dr. Christian Hermansen here today. We're going to get started with our polling questions. All right. And I think that we have everybody that we're going to for the answers for this one. So thank you for answering those questions. All righty. And next up, we have our lecture hosted by Dr. Kerr.
So today's session is about phenotypes of severe asthma. So what is phenotyping in severe asthma? Severe asthma is not really a single disease, and it's quite heterogeneous. And the concept of asthma phenotyping has really emerged to better understand the heterogeneity of severe asthma. The definition of phenotype is an observable characteristic of an organism resulting from the interaction between its genetic makeup and the environmental influences. The graph below illustrates symptoms on the y-axis and eosinophilic inflammation on the x-axis. Most asthma is concordant disease, such that as symptoms increase, eosinophilic inflammation increases, and symptom-based approach to therapy is often appropriate. These are the patients that are often seen in primary care. These are the patients that respond very well to symptom-based treatment. Allowing increase in the dose of inhaled corticosteroids to achieve adequate symptom control works well in this group. These are typically the patients that are seen in primary care clinic. However, many patients with severe asthma actually have discordance between their symptoms and their inflammation. On the y-axis, you could see patients who have discordant symptoms. So these are patients who have a lot of symptoms, but may not necessarily have a lot of inflammation. Monitoring inflammation in these patients can actually allow down titration of corticosteroids and limit the amount of medicine usage and perhaps even side effects. At the end of the x-axis, you can see inflammation predominant disease. These are patients who have tons of eosinophilic inflammation, but may not necessarily have symptoms on a daily basis, but may really only have symptoms when they have flare-ups. And monitoring inflammation in these patients can really allow targeted dosing of corticosteroids to lower the exacerbation frequency in these patients. And these are the typical patients that are seen who may have severe asthma that may be seen in a pulmonologist clinic. There are various factors that contribute to the phenotype of a severe asthma patient. First, it's the genes that somebody may be born with that ultimately get expressed in the person, that determine what the area anatomy histology will be. Ultimately, that determines the lung function. And finally, the patient that's sitting in front of us that demonstrates the adequate symptoms, the comorbidities, the quality of life, or the exacerbations that the person may be having. So there's a lot of background that ultimately determines who the patient is and what kind of asthma that they demonstrate. There are various asthma phenotypes that have been described, some better understood than others. One of the most common phenotype is childhood onset asthma. This is the typical garden variety. Patients get asthma when they're a child, they have a strong family history, they have a lot of atopy. Next is the adult onset. This can be both atopic and non-atopic asthma. Then there's a subclass of asthma patients who have sensitivity to aspirin, or they have aspirin exacerbated respiratory disease. And then there's this newer category called asthmatic granulomatosis that was recently identified a few years ago out of the University of Pittsburgh, where patients who had pretty uncontrolled asthma unconventionally ended up getting lung biopsies and were noted to have granulomas on the lung biopsies. They also tend to have typical findings of asthma on the lung biopsy. In addition, a lot of them had strong family history of autoimmune disease. Again, it's a newer phenotype that we're still trying to understand. Then based on the cellular inflammation, phenotypes can be divided into eosinophilic inflammation, neutrophilic, a combination or mixed, and then those with non-inflammatory asthma or quasi-granulocytic asthma. Then based on the clinical characteristics, these are not necessarily typical phenotypes, but these are patients that we've all sort of met in our practice at some point. There are patients who need tons of steroids and demonstrate some sort of glucocorticoid resistance. There are patients who are doing fine between their exacerbations, but really frequently exacerbate a lot. There are some patients who really have developed asthma only as they have gained weight or obesity related. There are some patients who have pretty mild asthma, but really have symptoms only when they exercise or exert themselves. And then a subset of women who develop asthma once they hit menopause or after menopause. Like I said, some of these phenotypes are a little bit better understood. A lot of this information has come out of the SARP, or the Severe Asthma Research Program, which took a cluster of patients who had difficult to control severe asthma and try and understand their characteristics and group them according to their characteristics or the phenotypes. And these are the three relatively better understood asthma phenotypes. The allergic asthma phenotype, these patients typically have early onset of asthma, perhaps in childhood or as teens. They have a lot of allergies. They often have seasonal variations in their symptoms. They may get worse in the spring or the fall. And that's when they end up with symptoms. That's when they end up with exacerbations. And they often demonstrate a strong family history. The next is eosinophilic asthma. These are patients, they have two-pronged types of asthma. One is when they have early onset. These people have allergies. They may have a high immunoglobulin E level. And there's late onset eosinophilic asthma. These typically demonstrate eosinophilic inflammation. These people typically tend to have a lot of comorbidities, sinus disease, gastroesophageal reflux disease, being overweight, tend to be more women. They may also have aspirin sensitivity. They are high healthcare utilizers. They have frequent exacerbation, emergency room visits, urgent care visits, hospitalizations. And some of these may even need to stay on oral corticosteroids for maintenance therapy long term. And then the last is the subset of neutrophilic asthma. This is typically late onset. Unlike allergic and eosinophilic asthma, the triggers for neutrophilic asthma typically are infections, sinus disease. This can be viral or bacterial infections, exposure to smoke, exposure to occupational sensitizers or pollutants. These people tend to have lower lung function and tend to be less responsive to inhaled corticosteroids compared to the allergic or eosinophilic asthma. They tend to produce a lot of mucus and may even have bronchiectasis associated with it. So these are patients who behave more like COPD patients. There's a phenotype of mixed eosinophilic and neutrophilic inflammation. This is not quite common and will often have overlap clinical features of both types of phenotypes. The non-inflammatory asthma, granulocytic asthma, these tend to have a lot of smooth muscle hypertrophy, airway remodeling, and hyperplasia. They may also have fixed or variable obstruction on pulmonary function tests. There are patients with fixed obstruction. Again, these are patients like COPD. They don't have a lot of reversibility on their pulmonary function tests. And there is a lot of speculation about who these people are. Are these people who've had a history of smoking? Are these people who've had severe asthma as a child and have just gone untreated for a long time? Are these people who are behaving more like bronchiectasis with a lot of mucus production, a lot of secretions? We don't quite understand. And there's this concept of phenotype of hyperresponsive or variable obstruction. These tend to have a lot of bronchial provocation, that their airways get irritated, whether it's a virus, whether it's an occupational exposure or a sensitizer. A lot of these patients have type 2 inflammation, but really can be seen in any type of inflammation. And four of these are the much less understood asthma phenotypes that are out there. So why am I giving you all this information? Why is it important to understand what the phenotype is for your patient? So we should really be able to recognize our patient's phenotype based on history, based on understanding what their asthma is like, what their triggers are. And hopefully that should allow us to take a peek inside at what's going on at a cellular level in their body, or understanding what their pathobiology is that's ultimately leading to the asthma, or what their endotype is. And once we understand this, the next step would be to really identify what is an appropriate treatment to manage that patient's asthma. This relationship between the phenotype and the endotype, unfortunately, is not linear and not predictable. And so that's why the role of a biomarker has risen. Biomarkers allows us to understand if for a particular phenotype, what is going on at a cellular level, what kind of inflammation may be occurring in the patient's body. And biomarkers also allow us to target appropriate treatments personalized to their type of inflammation. Thank you for listening, and we'll open this up for some question and answers.
All right, thank you everyone for watching. As always, we open up the floor to Dr. Jassal with his key takeaways from this lecture.
So the subject matter for that talk largely resolved on the concepts of endotype and phenotype. And the way that I like to think of phenotype is sort of the catch-all terminology. It is all the interactions that occur genetically, histologically, clinically, environmentally. Everything gets fed into that phenotype bucket. The endotype is one of the most important terms to recognize because that's the biological term. That is the term to help explain and break down the types of inflammation we're seeing. And that's really critical when we get to the biologic parts of conversations in terms of eosinophilic or is it neutrophilic, a mixed or maybe not much of all. But that's the best way that I like to look at all those put together. Now, we did mention, Dr. Kerr did mention about childhood asthma, and yes, that represents the bulk, and most of it is allergic asthma, most of it is steroid responsive. But one way I always talk about this with families is when I talk about asthma, I like to talk about it over the lifespan of an individual, because most just want to know how long is it going to last for, and are they going to outgrow it, which is a term I really don't like. Mainly because I think it's more appropriate to say your asthma is in remission more than anything else. So most don't have symptoms in adulthood who've had bad asthma or significant asthma as a child. But when those same individuals who tend not to have major symptoms regularly as an adult, when sick with a cold or with a significant viral trigger, it's not too unusual to see these individuals sick for maybe 2 weeks, maybe even needing steroids briefly during a time point of illness. So it's not unusual. So once again, although childhood asthma falls in that bucket of maybe you'll outgrow it, think about it in terms of the lifespan and using the appropriate terminology. Now, Dr. Kerr also mentioned about trying to break down the type of inflammation, eosinophilic, neutrophilic, mix. So usually what I do is I get lab work on anyone with severe asthma. With the moderate asthmatics, I'm starting conversations, and sometimes I do, depending on the situation and the evolution of the disease process. But anyone with severe asthma, I'm almost always getting a CBC with a differential because I want to know what that eosinophil count is. Also, I want to make sure I'm not missing any other potential immune or infectious disease process, but I want to know what those eosinophils look like. I want to get a total IgE level because I want to know that allergic-like response, and I want to get an aspergillus antibody test because that fungus exists everywhere. It's in the soil, it's in the dirt. Kids put it in their mouth. And then I also want to get an allergen panel as well too. I focus mainly on perennial aeroallergens, the stuff that we see all the time, dog, cats, dust. These are important to me. The reason is it helps me understand their endotype, and it helps me also understand if I have a biologic in my back pocket as well too, if they don't respond to conventional medicinal or inhaler-based forms of therapies. Now, in terms of kids, we're going to see largely allergic and eosinophilic processes. One thing I forgot to mention about the labs that I talked about, I don't like to get labs when they're on steroids. With the one lab I very much don't like when they're on steroids is the eosinophils because they often get driven down. So for me, for a lot of my severe asthmatics, unfortunately, follow-up is really tough for a lot of them. So I see them when they're hospitalized, and when that happens, I really have to negotiate to get labs after admission. So it gets a little tricky, but it's an important thing to know. But with eosinophilic, we are more likely to see that in children where the mixed bag is mostly seen, or the neutrophilic bag can be seen quite a bit in the adult population. Now, Dr. Kerr did mention about neutrophilic inflammation. So my alarms go off when I see a lot of neutrophilic inflammation and I hear the diagnosis of asthma in children. So when I see a lot of neutrophilic inflammation, one of the big things that I think about are potentially usage of perhaps substances which the children shouldn't be using, e-cigarettes, for example, have been linked with higher amounts of neutrophils. So I think about e-cigarette usage in our adolescent and now unfortunately in our pre-tween population as well too. And I think of marijuana usage too. Marijuana can also be linked with higher amounts of neutrophilic inflammation. So, and then not that we see that much in our obese population, because obese asthmatics, especially in the adult population, tend to have more neutrophilic or steroid-resistant population or steroid-resistant inflammation. But I do, but I do predominantly see obese patients with just eosinophilic inflammation. But I wanted you to keep that in the back of your mind if you happen to see one of those neutrophilic patients. And then the final part of this that I want you to take away with was the clinical response. So I boil it down to simple things just because I can't remember that many things during a clinic visit. To know if there's a good response to asthma or not, all I do is I ask two questions to figure out if it really is asthma and to get a good sense of what kind of phenotype I'm looking at. If I give you steroids, do you respond in the first 24 to 48 hours of getting steroids? And question two, when you get albuterol, do you feel better within the first 2 to 20 minutes after taking it? If you can give me that, you've given me a tremendous amount of information about your phenotype and those key variables. And I think there was some information put in the chat about questions as well too. Ashley, is it okay if we address those?
Absolutely, this is a great time. So we'll just go through them in line. Patrick asks, which phenotypes are type 2 and which are non-type 2?
Yeah, so type 2 tends to be more of the eosinophilic inflammation, while the non-type 2 tends to be more of the neutrophilic or could potentially be some of the mixed inflammation. Type 2 is what we see predominantly, vastly in children. So that's why they tend to respond to steroid, be it oral steroids and or with inhaled steroid-based forms of therapies.
Thank you.
Our next question we have from Melanie and a response also from Manuel. Does COVID cause asthma to get worse or does asthma make COVID worse? And then Manuel said that anecdotally he had some patients with asthma and COVID who showed no difference in their symptoms.
Yeah, so we've had a couple patients. So right now on our service currently, we have a couple patients with COVID who have some respiratory symptoms. They've had some have had distant, not active histories of poorly controlled asthma. So, but if you look at the broad data in children, there is a link between having a diagnosis of asthma and demonstrating the need to be hospitalized. But with that being said, that data is not really great data, mainly because it's looking for a diagnosis of asthma, but is not looking so much at the recent control of asthma and the COVID-like symptoms. I will say that from my own experience, for my poorly controlled asthmatics, the ones who are either in that moderate or definitely severe category, the ones who have contracted COVID during this current time period, especially during the second wave, have not had major exacerbations that have required admissions. And we were thoughtful of the use of steroids therapies because we don't want to excessively treat with steroids during this moment. Because there is a different protocol, of course, for COVID in terms of the appropriate dosing and the duration. But for me, I'll treat it like an asthmatic just because of the nature of the symptoms if I'm concerned, but I usually reduce the treatment interval to just 2 or 3 days. Frankly, I think 5 days is always too long for treatment of asthma exacerbations, and I think you can reduce it down.
I would just chime in to agree that I don't think that COVID has been making diagnosed asthma kids worse. But I fear that there's been an underdiagnosis of kids that didn't previously have a diagnosis of asthma because we are not able to either get people in because of telemedicine or whatever, and we haven't been able to do spirometry testing for screening or at least working issues up. So I think there's going to be a cohort of kids that probably could have been diagnosed with asthma that we really can't get into the office to get appropriate diagnosis done. As far as my reaction to the lecture, which I thought was very good, I think this is relatively new material for those in family medicine, we've been taught kind of that typical symptoms and inflammation kind of go in that axis. And those 2 degrees of neutrophilic and eosinophilic is something that didn't really hear much about in medical school. So this is kind of helping us broaden our differential and kind of consider other options when we get to someone who has severe asthma. And I just want to applaud Mandeep as a pediatric pulmonologist to also get angered when people say they grow out of their asthma. That has been driving me nuts. So I appreciate that I have that backup from Mandeep.
Thank you so much, Herm.
And Ashley, there was one other question that Melanie posed. I think it was in the beginning when she wrote why postmenopausal.
Oh, missed it. Yes, let's take a look here.
So Melanie, I'm not in, by no means am I going to comment on too much on the menopausal components or the concerns for that, because I'll defer to my adult colleagues in regards to that. But I do want you to have one major takeaway from a pediatric standpoint, that it is not unusual to see asthma get worse in poorly controlled adolescent girls. So adolescent girls, and we think this has to do with estrogen and progesterone changes, with the key thing being estrogen in this case. So I'm going to make the assumption it could be postmenopausal issues too, but I'm going to leave that one up for the experts. But we think what happens is with the estrogen changes that happens around puberty, it makes the airway more hyper responsive. So it is because of that if you already have an adolescent girl who's poorly controlled, it only gets harder. The other thing that's really interesting is that no matter when they do get hard to control, it's really hard to get controlled even with good compliance with inhaled steroid therapies. So when that happens, once again, going back to the lecture, think about lab work, figure out what kind of inflammation. And I do see somewhat of a slight increase in the amount of neutrophilic inflammation at that point. So I do give a heads up to parents when I counsel them on what the future may hold, that sometimes these adolescent girls do get worse, while the boys in general do get better over time in terms of improved levels of asthma control.
Thank you. Let's see, we've got one more question here from Ivy. Do you tell patients to throw away and get new inhalers after a viral infection?
I'm really interested to hear what Andrea and Erm have to say about this, because they probably get a lot more of those questions. I don't tell people to throw away their inhalers after a viral infection. I think people should routinely clean, the external surfaces and things like that, but I don't, but I'll defer to them and their answers as well too.
For a lot of my patients, it's pretty expensive for them to get the inhalers they got in the first place. So I don't want them throwing their money away in that regard when they can potentially sanitize things. So no, I haven't been able to, or haven't been telling people to do that. I don't know about Andrea.
Yeah, it's the same here. They're expensive as they are. We do recommend they throw away their toothbrush and start with something fresh. But as far as inhalers, no, if it can be cleaned. And just to jump back to a little bit of the discussion about menopause. So we also find that a lot of women during that time of the month also seem to have a little bit of a flare up with their asthma. And once again, we feel that that's tied to the estrogen and progesterone. And as someone who's postmenopausal, I can tell you that it does get quite worse during that time when you're going through menopause and then postmenopausal, because just the hormone changes. So you're right, it happens when you're coming into, as young girls are developing, and then same thing on the other end. As we're on our way out, we have problems as well, sadly.
Thanks, Andrea. Thank you, Herm. Okay, we got a couple more questions before we go on to our case presentation. We're still making great time. Thanks, everybody. Patrick asks, what are the parameters that should be monitored to assess the progression of asthma, and are there differences in asthma phenotypes? Start with that one.
That's a great question. And it's like Herm mentioned as well about some of the changes in the new COVID world. But so my parameters I look at for every clinic visit is, before I even get to them, they're stopping by the lung function laboratory, at least in the pre-COVID world we lived in. So lung function is really important to me, because if I can't normalize lung function, then I often find myself in a situation where I discuss about the long-term impacts of asthma and likely having significant asthma as an adult. So when we talked about, especially in that first lecture, about the histological changes associated with poor asthma control, thickened basement membrane, increased mucus inflammation, those kinds of changes I often will think will be present if you have poor lung function. So lung function is something I use to monitor. The other one is I'll always assess for ED and hospitalizations and use that as my marker for general improvement. And then steroid usage, which is of course linked with that. In terms of the hospitalizations too, so you always want to take a look at the need for non-invasive and invasive forms of ventilation. So if you are creeping up and needing non-invasive, not just once, but 2 times plus, I'm almost always going to be going down the path of severe asthma workup with you, because you inflame quickly, and you inflame to the point of being highly consequential. So that's why BiPAP usage, and in the rare cases, intubation, very rare cases, intubation, are important. And then for beta-2 agonist use, I think one really nice time point for this talk is to talk about the new NIH guidelines that were released in December of 2020. And that consensus statement said if you have greater than if you need a beta-2 agonist, albuterol, more than 2 times per week, you have poorly controlled asthma. So you can use that as one of the parameters for you as well. And then I'll use other components too, like exam-wise. But normally for me, my parameters, with the exception of lung function, just comes with a good history. A good history is more than enough. And I think Herman and Andrea were talking about in the past about the use of asthma control tests as well too, because it's really important to focus on patient-reported outcomes. Not so much what we care, but what they're really reporting, because we need to respond to them and to their symptoms as well too. And then are there differences in asthma phenotype? All of it come together in terms of saying if you have a severe phenotype, you're more likely to have progression and uncontrolled disease, and therefore need to elevate the number of inhaled steroids, the dosage of inhaled steroids, or the types of biologics we may need to employ.
Yeah, I think now that we're doing so much telemedicine, that asthma control test and then the rule of 2s, you have to use it more than twice per week. That's how we're kind of determining control when we can't actually see the patient in person. I also put in there in the chat the labs that Mandeep mentioned as far as evaluating types of inflammation. I was kind of hoping that Aspergillus would autocorrect, because I know I spelled that wrong, so I apologize.
Thank you so much, Herm, for adding that in. Yeah, just for our folks who might watch this after, that's why I read everything out on the chat. So Colleen asked what specific labs you use for evaluating types of inflammation. And so Dr. Hermansen added in CBC with diff, IgE, Aspergillus, and allergen panel. Also check medication compliance, spacer use, and smoking status. Things that can be more correctable and common. And then Andrea added in that great link, another great link that we'll add to our resource center, that it's important that patients are cleaning their medicine canister kit. So we've got that in there.
Yeah, can I just jump right back to that? That's when someone asked about someone throwing away their inhaler. No, but we're finding people aren't cleaning these. They're kind of, if they have pneumonia, bronchitis, whatever, and they're doing this every 4 hours for a week at a time, and people will just leave this connected to the nebulizer and then they'll just throw it on their counter. We want them cleaning it every time. The guidelines are in there, as well as they need to sanitize it once a week with a mixture of hot water and vinegar, and it needs to be stored in a plastic bag. Don't leave it on the countertop while the cat's walking all around it. So we see a lot of that as well.
Thanks so much, Andrea. Alrighty, I think we can probably answer this last question quickly before we move on. Ivy asks, in exercise-induced asthma, don't we tell kids to use albuterol prior to sport? This may increase frequency of use.
That's a really, really good question. So Ivy, I'm gonna respond to first thing saying that EIB is often overdiagnosed in the general population. If you have an underlying diagnosis of asthma, be it mild, moderate, or severe, and if you report symptoms during exercise, I believe you. However, if you're not having an underlying diagnosis of asthma and you say you have exertional dyspnea or shortness of breath with exercise, I'm not as inclined to believe that you have exercise-induced asthma, because the 2 most likely reasons that I've seen on the exercise studies that I interpret are usually you're deconditioned. So you just need to work out a little bit more, which we all know in this post-COVID, in this intra-COVID world we live in. That's easier said than done. And then the second one is poor breathing technique or dysfunctional breathing, especially where kids hyperventilate or hypoventilate when they're breathing. And that usually means that for EIB in a non-asthmatic, usually what I tell them to do is just non-medicinal or non-inhaler-based forms of therapy. Now, for the EIB component, I would separate the need for just absolute pre-dosing before sports between the need for rescue albuterol. So you have to differentiate prophylactic use from rescue use. But another important thing for athletes too, so just so you would know this, you want to give athletes, if you are a truly competitive one, 2+ of albuterol sort of built in our head from all our training. But these are somewhat antiquated notions too, that sometimes athletes need more puffs of albuterol. And so for a lot of my more aggressive athletes, especially this is the state of Maryland where we have a lot of swimmers, I'll often recommend sometimes even up to 4 puffs of albuterol prior to sports. I would point you to some good literature on how the link between EIB, especially in swimmers, to help you kind of guide your notion. So, and also to treat that EIB, good warm-ups. Warm-up routines are absolutely critical. Kids don't warm up because of this, right to finishing class to working out right away. That doesn't make any sense.
Thanks so much, Mandeep. Alrighty, I think now is a great time for us to scoot over to our case presentation. Mandeep, take it away.
So this is an 8-year-old African-American girl who was born at 27 weeks gestation. She had a history of prolonged usage of positive pressure ventilation. When we think she developed her first, or at least the mom thinks that first asthma symptoms were in the first year of life, no known viral triggers. Her symptoms are typically cough and expiratory wheezing, so classic asthma symptoms. But like I said earlier, yes, she responds to albuterol. Yes, she responds to steroids when we want her to. In terms of triggers, she has upper respiratory tract infections as well as outdoor allergens. She's had allergy testing done before as well. We think there's indoor allergens as well too, and exercise is also a trigger. So in terms of her controller medication, she is on a lot. She is on Zolair, which was started 6 months ago, which we're giving every 4 weeks. She's on a moderate dose of Advair twice a day. She's on Spiriva Respimat once a day. She's using albuterol as needed, and she's also on Singulair once a day as well too. And in the past, she had poor control with Flovent alone. There had been no concerns for adherence. That was documented by a great refill history. She's had many hospitalizations over her lifetime, 7, 2 requiring intensive care requirements. Those are all for asthma. And like I mentioned earlier to you guys, she did need BiPAP on those. And then she's had 2 ED visits over the past 1 year. And her last asthma control test was not good, with just a score of 6. She does have a history of chronic lung disease, which complicated the diagnosis concrete diagnosis of chronic lung disease of prematurity. There is a strong family history on both the paternal and maternal sides. She is occasionally treated with antibiotics along with her asthma exacerbations, because concerns for this pneumonia-like picture, sometimes on x-ray, sometimes not. She's had a normal echocardiogram. She was treated with GERD as an infant. It didn't seem like it really helped too much also when it was attempted. She does have a history of atopic-like kind of disease with rhinitis. She does have some snoring, but her sleep study was non-significant at less than 2 events per hour. She doesn't have any baseline levels, baseline ventilation needs, and otherwise her review of systems does have a history of anxiety from a behavior standpoint. Is on allergy-based medications in terms of Claritin and Flonase twice a day. Prior to starting Zolair, the labs that were acquired showed an elevated eosinophil count of 0.25, 0.15 being our cutoff, not too high in terms of 0.3 being the probably more appropriate cutoff. Her total IgE was elevated at 522. She didn't have any aspergillus antibodies and didn't look to show any signs of significant inflammation. Her vitamin D levels looked to be good. She did have notable sensitivities to allergens as well too. In terms of the diagnostic panel, she had PFTs that were performed. She was getting okay with the technique, but she did demonstrate some possible small airway obstruction. But this was done after starting Zolair. But I think pre-Zolair, we did have a bit of a difficult time trying to get this little kid to do lung function appropriately. I think there may have been some developmental issues as well too. But I did mention about this moderate obstruction component. Sleep study, like I mentioned to you earlier, was non-significant. Her weight and height were great. She tracks always around the 25th to 50th percentile. She does have a little bit of that adenoid-like facies, mouth breathing. She has some expiratory wheezing. But 6 months onto biologic therapy and on a lot of asthma medications, which is a huge medication burden for the mother and for the child herself, can we wean her daily asthma controller regimen? How long should we maintain on Zolair? And is there any other further diagnostic workup that you think is indicated now that she's been on Zolair for 6 months and doing much better on therapy?
Thank you, Mandeep. Yeah, feel free to jump in, anyone with your suggestions.
I think one thing to point out also is that it's not just the technique of the spacer and the inhaler use that's important, but I wonder if their technique of their Flonase is decent as well. Most people will jam it right up there, and then if they're wondering why they're tasting it, it's because it's not in that spot anymore, or they blow their nose right afterwards. They're snorting it. So that technique is something to consider. She has a pretty decent allergy to cats and dogs, and she's probably not going to get rid of the cat, but I'd probably advise her not to try and go to vet school. But I wonder if she would be a candidate for allergy immunotherapy.
You brought up two really good points. The first that I'm interested to is the Flonase technique. I have a bit of evolved my approach lately just to get a better effect with Flonase. So I've been finding that if a kid can use saline rinses, I'll often tell them to use saline rinses first and then introduce the Flonase. But in terms of using the Flonase, you're right, like it's all over the place that now I have to get right in their face to kind of demonstrate how to properly use the medication. And then you mentioned about subcutaneous immunotherapy. So this is once again one of those where I would suggest the participants take a look at the new NIH guidelines, which had an entire update. So the 6 updates, one was dedicated towards allergen therapies. And so right now the NIH is saying if you're 5 years and older, with relatively well controlled, so this won't apply to the severe asthmatic, but now for this girl who we now finally got under good control, who could qualify, if you notice that there is a clear link between trigger exposure and asthma symptoms, you probably could be a good candidate for therapy. They're not recommending sublingual immunotherapy. Although that's really appealing for people like you and me who, maybe we could pull that off in office settings and things like that. And it's probably way more pleasant on kids who don't have to get a shot and then stick around for a while to see if they get a reaction. But subcutaneous immunotherapy is the recommended approach if you do find that there's a clear trigger and you are well controlled prior, during, and while you're in that maintenance phase of subcutaneous immunotherapy. So I think she would be a good candidate for that as well too. And I don't know if Shannon and Kim, I believe you guys work in an allergy office, do you not? Yeah, do you guys have any comments on that?
Yes, we give a lot of allergy shots. I told Shannon a minute ago, I don't know that weaning the medicines just yet would be a good thing for her. Maybe on Zolair a little longer. And then, yes, allergy shots I think would be a good thing for her with the Zolair and the medicines, because I did notice she had big reaction to the dogs on her RAS test.
I think it would be helpful to see what their home looks like as well. So if they have pets in the home, and people are very reluctant to get rid of their pets, and I understand they're a member of the family. So we really have to meet them where they are and say, is there at least one safe room that you can have in the house? Could your bedroom be your safe room? That cats and dogs aren't allowed in there, and that you're keeping it vacuumed? And would it help to have a air purifier in your room? Would it help to have dust mite proof mattress pad covers and pillowcase covers, and do this whole approach to trying to make at least one room the safe space? And then if she is cuddling with dogs or cats or something like that before she goes to bed at night, could she shower before bed so she could get all that dander off of her skin and her hair and her clothing and everything? So looking at some of those environmental things too, I think would be really important.
Yeah, Andrea, the NIH also, that most recent update addressed allergen components in the home, like what's the best way to address those. And I think what they were recommending is not just singular approaches, like just don't put a bed sheet on it, right? Like do like some multi-component interventions.
Yes, and we even teach people to make sure that they're changing the furnace filter and what's the MERV rating on their furnace filter. And so we go through everything. Absolutely, the national guidelines are, we want this to be a whole focused approach. One thing isn't going to make a difference. So yeah, absolutely. And some people, it even helps to clean out the vents. If there's a lot of cat or dog hair in the vents, there's a lot of environmental things we can help them with. Yeah, good point. Yeah.
Because we used our patient lived in Baltimore City, so we referred to our local Department of Health, so an individual like yourself, to help us with remediation efforts for this family, which has helped.
Yeah, that's a good point, because expecting families to pay for all these different HEPA filters and everything else may be cost prohibitive. So if you can reach out to other resources for the patient, it may be beneficial, or get a fish.
And one thing I think we mentioned on a previous boot camp is that there is nationwide Green and Healthy Homes initiative. We have one in Salt Lake City. I don't have one in my county, unfortunately, but they are able to go in and mitigate and to replace carpet with solid surfacing. They can help with furnaces. They can provide HEPA filters, HEPA vacuums, all sorts of things, air cleaners. So that's something that I know we can send to Ashley, and she can send that out to the group. And yes, okay, it's already there, never mind. So that is a good resource too.
Do we have any other suggestions for this patient from the group? Otherwise, Mandeep, you can feel free to summarize if you'd like.
Sure. So we had a very young 8-year-old African-American female with severe asthma that is now well controlled with the addition of a biologic. So it's on now a pretty extensive multi-drug controller regimen. And now we're at the point 6 months into therapy. Now that we have improved control, we're trying to come up with the next steps. So since the start of writing that case study, we are now well into her control as well too, but we are not going to stop. I agree with Kim and Shannon about continuing the Zolair therapy. It is way too early. We want to keep on going, get good control for quite a while. Usually I continue for a minimum of 12 to 15 months and usually longer because we really want to get good control to allow those airways to really heal up, to give us a good possible chance to give those other forms of non-biologic therapies the best possible chance of working. There is no perfect way to tell you when to stop it. There are no great guidelines in regards to that. So a little bit is clinician dependent, but that is a very important point. Now, in terms of which medicines we eventually did stop, the first one, and I'm always keen on trying to do this, is Singulair. Now, I might be a little bit different than some people on this call, but I'm not the biggest fan of Singulair in general. And Herm is probably getting a lot of phone calls, and I've gotten my share too when the black box warning came up on Singulair in February or March of 2020 with a concern for neuropsychiatric events associated with Singulair. They were nothing new. We knew about them for a while. It's just the FDA wanted to elevate it to the point that we would all start paying more attention to those symptoms. More often than not, I usually see nighttime hallucination or nightmares associated with it, but it can be other mental health issues as well too. I've had a couple cases of suicidal ideation on the therapy. But if I can get you off of it, I will. And not only just because of that, it's largely because I don't think it's that effective. If I'm going to give a LABA or if I'm going to give an inhaled steroid, I'm going to go with that as opposed to a Singular or a leukotriene antagonist, because I'm getting more bang for my buck with the LABA and the ICS.
Yeah, I agree. You know, unfortunately, right when that announcement came out is when COVID hit again, so all my phone was ringing because of COVID. But the only advantage I think to having Singular is it's oral, so you don't have to worry about technique as much compared to the other medicines. But you can teach technique, so I think that makes sense.
And then for our next objective, it was to eventually start weaning down on the inhaled steroid as well too. And we're going to be seeing her back, oddly enough, next week. And I'm going to have a conversation with her about using perhaps as needed or rescue LABA ICS therapy. I think she's that well controlled now that we can start to use our LABA ICS agent as our rescue agent. So I'll convert her over from Advair to Symbicort, mainly because that's the one that's been studied and I think she'll do well. That is her controller and as her reliever therapy, otherwise known as SMART, S-M-A-R-T therapy.
All right. Well, if anyone has any questions or comments, feel free to raise your hand or add them into the chat. Otherwise, we can get started. Mandeep, did you have anything else about that patient you wanted to mention? Is that it?
I think that's it. She's doing great.
All righty. Well, in that case, we can get started with our post-test polling questions and some of our housekeeping stuff. Like I said, if you have any questions, go ahead and add them into the chat now. So for our first set of post-test questions, we have question number 1. I will now use phenotypes to classify severe asthma in my patients. Strongly disagree, disagree, neutral, agree, strongly agree. Question 2, how confident are you now in identifying phenotypes of severe asthma? Not confident, slightly confident, moderately confident, or highly confident? Thank you, everyone. Alrighty. And for our post-test knowledge questions, we have, which of the following statements is true? An endotype is the external observable characteristic of an organism resulting from interaction between its genetic makeup and environmental influences, or a phenotype is the external observable characteristics of an organism, etc. Question 2, which factor contributes to the phenotype of the severe asthma patient? Genetics or hereditary factors, environmental influences, inflammatory mediators, or all of the above? All right, Mandeep, so how did they do? Oh, you're muted, sorry.
It was excellent. So which of the following statements is true? You are all correct. Phenotype does describe all the external characteristics that depend on genetics, environment, histology, lung function, clinical presentations. And which factor contributes to the phenotype of a severe asthma patient? Everything, like I mentioned to you earlier. That is the bucket. That'll take in all those kind of components. And so all of the above was the right answer.
Well done, everyone. Thank you. Alrighty, so we're coming up to the end of our session. So as always, I just want to ask the group, does anyone have a patient case that they would like to chat about next week? Any lingering questions about any of your asthma patients that you're currently treating or you've been treating? All right, well, that's okay. We always take a nice long pause and see how everyone's feeling about that. We do have a question before the end of the session. Ivy asks, how long do you use Spiriva for rescue?
So I don't use Spiriva as a rescue inhaler. Spiriva is a long-acting muscarinic antagonist. Oh, I just saw you say sorry when you're muted. But yeah, it's a controller-based medication. Just so you know, just to differentiate, the NIH did not make a comment about Spiriva in the ages of 6 to 11-year-olds because there aren't great systematic reviews to look at the usage of Spiriva in that population. However, greater than 12, they did recommend it as a potential add-on therapy. And if you are going to use it as an add-on therapy for anyone greater than 12, adolescent or adult, they were going to recommend it as in those who are on a LABA ICS as opposed to just an ICS alone. So just to review, if you're on a LABA ICS, it's a good add-on. It's a preferable add-on agent. If you're just on an ICS alone, you can add it on, especially if LABA is contraindicated, but preferable in the LABA ICS population. Why? You have to go back, I think it's in 2015 or 2016. The study is called the BELT study, B-E-L-T, and that was predominantly in African-American adults. And what they saw was worsened exacerbations on those who are using the Spiriva ICS as opposed to the Spiriva ICS LABA combination. So, for me, who predominantly takes care of a lot of African-American populations with asthma, I'm very thoughtful about, the populations I'm going to use my Spiriva on. And then, but Nih Guidelines, the one that Dr. Kerr mentions in her talk, that does talk about the usage of Spiriva for those greater than 6 years of age, Spiriva Respimat, which I believe in as well too. But the final point is that if you are going to prescribe it, just pay attention to the major side effects: glaucoma, worsened urinary retention. And I don't really see that many cases. Herm probably sees a lot more of those kind of concerns than myself. But it can potentially worsen headaches or sinus disease. And so those, I'm really thoughtful about employing Spiriva.
I think the correction from Ivy was actually about Symbicort. How long do you use Symbicort for rescue?
Oh, I'm so sorry. So for Symbicort, you would use it as your preferred agent. So I would use Symbicort now as my rescue therapy out the door. So you can use, so right now, it depends on age right now, and it depends if you follow the GINA or the NIH guidelines. The preferable agent for mild intermittent asthma right now, the number one preferable is albuterol is needed. But if you are going to use but if you are going to look at an alternative, Symbicort is needed would be a reasonable backup option, especially in those 12 years of age and greater. And for mild persistent asthma, you can also use it as needed. And the third backup option is, because a lot of people don't yet feel comfortable using Symbicort if you need it, is you can use an ICS and albuterol together, so concomitantly. So every time I pick up my albuterol, I'm picking up my ICS. Albuterol first, 2 puffs, and then ICS, usually low to moderate dose. And then in terms of trying to give you a sense of how much is right, just so you kind of know that for that population. So the studies that were done in kids, beclomethasone, so QVAR, about 256 micrograms per day had been studied. So it just gives you a sense, 40 micrograms per actuation, 80 micrograms per actuation of QVAR. So total dosage of beclomethasone, if you're going to use that ICS LABA, would be 256 micrograms. For those using Symbicort as your reliever therapy, because you're probably going to ask me, or probably wondering, what are you going to do with asthma action plans? Because the typical ones don't make sense. I strongly recommend you Google the NIH guidelines, the new ones, December 2020 update on the action plan, and you're going to see a new modification into the yellow zone and somewhat in the red zone. But you're going to talk about the number of puffs of Symbicort. So for anyone who's 12 years of age or greater, so an adult, maximum range is up to 12 puffs a day of Symbicort. So that's going to be your as needed approach or rescue approach. If you want to think of totality, for 6 to 11, it's going to be 8 puffs. If you follow the GINA guidelines, believe it or not, they're going to allow up to 72 micrograms a day. So that's a lot more. But just gives you a sense of, I stick with the 12-8 differentiation. So hopefully that makes a little bit more sense for you.
And Mandeep, when you were talking earlier about uncontrolled asthma, and we had said that albuterol used twice a week is considered uncontrolled, are you still using that rule of 2 for your Symbicort?
Correct. So because Symbicort will be my rescue drug, so I'll use that as my preferred approach. And the things get a little bit tricky, Herm, when you are talking about in that red category, like, what are people supposed to do? Like, are they not going to use their albuterol? Well, technically, they're going to use one inhaler, that being their Symbicort, the only one that's really been studied. But if you are going to use just that and prescribe just that, you would give your 2 puffs back to back of Symbicort, and then on your way to the hospital, or starting to use your steroids. And there's some good international references as well to Australia, Europe. They've been using these kinds of approaches for a little bit longer than we have, and they have good recommendations on that front as well too.
Excellent. Thanks so much, everyone. Well, we're going over time, Ivy. Thank you for another wonderful question. We'll maybe send that out to you via email. I just want to say thank you all so much for joining us today. We'll see you next week when we talk about endotypes and biomarkers of severe asthma. Oh yeah, Melanie knows what's going on. Echo clap for everybody. Thank you all so much. Have a great week. We'll see you soon. Bye-bye.